Just a reminder to please leave your questions in the chat at the end of the presentation. And I would ask you to please fill out a very brief survey at the end of rounds. This will let us know that you were present today and will give us a brief survey on our presentation. Today's presentation is being brought to us by the Division of Respirology, and we have Dr. Schwartzman, who is going to introduce our speaker. Thank you.
Great, thank you, Nadia. So it's my great pleasure to introduce Dr. Sana Swaleh, who's one of our newest members. Dr. Swaleh completed her medical school at the Université de Montréal, followed by internal medicine residency in the McGill system based at the JGH, and then respirology residency here as well, after which she undertook a clinical fellowship in cystic fibrosis at the University of Toronto with support from Cystic Fibrosis Canada. And during that time, in addition to focusing obviously on the management of cystic fibrosis, she's also developed a significant interest and expertise in non-tuberculous mycobacterial lung disease and non-CF bronchiectasis. And just to put this in context, many of you will know that in decades past, CF was an almost uniformly fatal disease, often in teen years, early adulthood. And things have really changed dramatically for a number of reasons. Much better supportive and anti-infective care, true multidisciplinary care, and recently some major breakthroughs in treatment, really guided by the sort of molecular slash phenotype correlation and clinical decision making based on that. So I'll let Dr. Swaleh illuminate us, but this is a super exciting time to be involved with cystic fibrosis, and we're delighted to have Dr. Swaleh bring us up to date. And the last point is that a lot of our advances in CF care here at the MUHC have really been due to the leadership of Dr. Matuk. I'm not sure if he's on this call, or he'll be joining, but really we have an outstanding CF clinic, which Dr. Swaleh joins in large part due to these colleagues. So go ahead and thank you, Dr. Swaleh, for joining us today.
Thanks so much for the very warm welcome. I'll be talking about CF and the new era of highly effective modulator therapy. Thanks so much for inviting me as well to speak today. So I have no relevant disclosures, and I'll jump right into it. So the objective of the talk today is really to, one, help the general audience who are less familiar with CF perhaps to understand better the epidemiology, the pathogenesis, and the broad multisystemic clinical manifestations of CF, understand the therapy burden of CF, and then spend some time exploring what the groundbreaking therapeutic advances of these new highly effective CFTR modulators are. And to understand where we are today with CF and appreciate all the advances that were made, it's helpful to take a step back and talk about where the story of CF began. So it begins with disease recognition, which is credited to Dorothy Anderson, who first recognized the disease. Dr. Anderson wanted to be a surgical resident, and this was denied to her because she was a woman, and so she became a pathologist instead. And by becoming a pathologist, she has completely changed the face of modern medicine and the face of CF as well. She noticed that there were a series of infants that were dying from what was called celiac disease, who were very emaciated, who had these bloated bellies, very malnourished. But on autopsy, they had a really strange-looking pancreas. Their pancreas were at areas very fibrotic and at areas very cystic and abnormal-looking, which is not classic for celiac disease at all. And it occurred to her that this is probably an entirely new disease entity. And in 1938, she published her seminal paper called Cystic Fibrosis of the Pancreas, where she reported 44 cases of such babies with this disease at her hospital and in surrounding hospitals as well. And that therein where the name comes from of cystic fibrosis, and in French still referred to as FKP, or Fibrose Cystique du Pancréas, from this original pathologic description. Medical historians can date back the early descriptions of CF probably from way back in 1595, when there would be theatrical autopsies. And Dr. Pao described this 11-year-old girl who was bewitched, and she had a pancreas that was very wooden and swollen at the same time. And in the 1600s and 1700s, they would say that children who had an excessively salty taste to the skin were bewitched, and they were not long for this world. So not much about CF was known at the time when it was first recognized as a disease, but what was well known is that there was clearly a very significant life shortening with the people who had these disease. And then as therapeutic innovations developed, there was incremental changes in life expectancies. As Dr. Schwartzman had mentioned, antibiotics and better nutrition and a bunch of other disease innovators that had helped the life expectancies of these children. But it was all the way in 1989 when the CF gene was first identified, and was first identified to be localized on chromosome 7. It was an international effort, but this effort was really in large part contributed by Canadian effort as well, and Dr. Tsui in particular from Toronto that contributed to the identification of the CF gene. 3 historic papers reporting on the identification of CF genes were published in Science magazine in 1989. And then this spurred on later the year after the start of the Human Genome Project that started in 1990. Today, we have a much better understanding of CF as a disease entity as compared to way back when it was first described. We know that it is inherited. We know that it is an autosomal disease, so it's not sex-linked. We know that it is recessive, therefore it is inherited from mutations from each parental allele. And it is a multisystemic disorder that's characterized by abnormal ion transport on the secretory epithelia that's present a little bit everywhere in the body, in the sinuses, in the bronchi, in the biliary tract, in the pancreas, the intestines, and reproductive system. And it's characterized by really thickened and viscous secretions. And these thickened and viscous secretions and abnormal ion transport is due to dysfunction or absence of the cystic fibrosis conductance transmembrane regulator, so the CFTR protein, that is due to mutations of the CFTR gene. It is the most common life-shortening genetic disease in Caucasians. Its incidence is roughly 1 to 3,600 live Canadian births. A lot more common in Caucasians, but with a lower incidence, but not 0 incidence in other ethnicities and other races. And the most common mutation is the F508 del, so the deletion of phenylalanine residue at the position of 508. Roughly about 4% of the general population are carriers of one mutation of the CFTR gene of delta F508, and they're completely asymptomatic. Now, the major cause of mortality and morbidity is really progressive respiratory failure, and lung function, so FEV1, the forced expiratory volume in 1 second, is the main prognostic indicator of lung function decline and of survival, essentially. And this is why cystic fibrosis, the primary physician of the patients with CF is really respirologists, but we highly depend and benefit from the expertise and guidance of our entire multidisciplinary halide healthcare team, but also on multiple other medical and surgical subspecialties that help us manage these very complex patients with really multisystemic issues. And with time, we've noticed that we can have, with all of the therapeutic innovations that were in place, we've been able to improve their lung function. But as you can see, the slope of decline has not been affected by these therapies. This is just to highlight that there's still a misconception in people who are less familiar with CF, that CF is predominantly a Caucasian disease or quote unquote a white people's disease. And still to this day, I have patients every now and then who are non-Caucasians, non-whites, who tell me that they've been told that it's impossible that they have cystic fibrosis. A physician had told them that it's impossible that they have cystic fibrosis because they aren't white. And so that can definitely lead to misdiagnosis. The incidence is lower in non-Caucasians, but it's not 0. This is the story of Terry Wright, who is a big advocate in the CF community and the CF Foundation and in the Black rights community as well. What we now know about the CFTR mutation is a lot more elaborate than what we knew before. So we know that this is a channel that is cyclic AMP regulated, chlorine dependent, through which chlorine passes, and we've also discovered that bicarbonate passes through this channel. It also affects other chlorine channels, and it inhibits ENaC. So this is a schema of epithelial cell in the bronchi, where you have CFTR that's present on the membrane. You have chloride and sodium that's going through it, and water that's following the gradient. You have the cilia that's above it, and a nice liquid airway surface layer. The CFTR is inhibiting ENaC here, the epithelial sodium channel. And so there's less sodium absorption, and there's less water that's going through. And so you have a nice liquid layer on top of which there is mucus that is nice and thin and easy for the cilia to move upwards and clear the respiratory tracts. In CF, however, when you have dysfunctional CFTR, you have significantly reduced chloride and bicarbonate secretion with less water following that gradient. You lose the inhibition of ENaC, so you have hyperabsorption of sodium and hyperabsorption of water. And so you have this really thickened, dehydrated layer, surface layer, in which there is really tenacious, sticky mucus, and there, in the acidic pH, there's impairment of phagocytes and macrophages as well. So there's impaired bacterial killing, and all of this presses down on the cilia and makes it very hard to clear the airways and very hard to clear the respiratory tract. CFTR is a very complicated protein. It's a complex structure that requires complicated folding for it to go into the right configuration. It comes out folded from the endoplasmic reticulum, but then has to be trafficked all the way up to the apical plasma membrane. And then eventually the late endosome will take it and it'll be degraded in the lysosome. But if it comes out not properly folded, then the proteasome is going to degrade it. It's two large membrane spanning protein with the nucleotide binding domains that bind the ATP. You have the ARB domain here that needs phosphorylation for the channel to open. So very complex. And there's over 2,000 mutations to date that have been discovered in the CFTR gene. Not all of them are disease causing, but there are a lot that are disease causing. And out of those that are disease causing, they can affect the protein in various different ways. And so they've been arbitrarily classified as 6 big groups of categories of CFTR defects. You have class 1 that results in no protein being formed at all. Class 2 that makes a protein that's very misfolded, so it does not traffic to the cell surface and gets degraded by the proteasome instead. And that's where the class that delta F508, the most common mutation, is a part of. Class 3, which is also called the gating mutation, is a mutation where the channel does not open. And class 4, which is it starts becoming more mild in mutations, is when it's less functional, so there's less chloride or bicarbonate that's going through. Class 5, there's less protein, overall, just in general, less protein. And class 6, it's less stable, so it's being degraded more quickly. So looking at this, you can appreciate that people who have no protein or no functional protein that are being made, these populations are going to have much more severe phenotype because these are considered severe mutations. On the other end of the spectrum, if you have just less functional protein or less protein in general, you're going to have much more milder symptoms because these are all more milder. These are more milder mutations. We in CF have used diagnostic guidelines, based ourselves on diagnostic guidelines to help us diagnose CF. Essentially, the principle is that there needs to be some clinical presentation of CF. So either a positive newborn screening, some signs or symptoms that are consistent with CF, family history of CF. One of those 3 combined with some evidence of CFTR dysfunction. So classically, sweat chloride testing that is very abnormal, 60 and above, 29 and below is considered to be normal, or some other CFTR physiological testing that is abnormal and consistent with cystic fibrosis, or the presence of 2 CF causing CFTR mutations in trans, so on each parental allele. It took a long time for newborn screening to be come to Quebec. It's now in 2018 that we have a universal screening across Quebec. We have universal screening. We have universal screening across Quebec. in 2018, and that's in large part due to the significant advocacy work of CF Canada, of patients, of families, and of physicians, including here at McGill, spearheaded by Dr. Lanz at the pediatric side. This is one of the studies that was published by Dr. Lanz's group that showed that newborn screening had a significant impact in the improvement of outcomes in infants. So newborn screened infants were significantly less sick, had less hospitalized days, less hospitalization, significantly better weight, significantly better height, and overall it was more cost effective for the system to have newborn screening. And so now newborn screening is universally implemented. But it took quite some time. It was 2007 when the first province in Canada, Alberta, implemented newborn screening. Important to know also just that newborn screening catches about 90% of patients. So there's about 10% of patients that are going to be missed by newborn screening. So screen negative does not mean that they will not go on to develop cystic fibrosis. Sweat chloride testing is just an illustration to show that it's quite simple. It's just electrodes that are placed on the forearm in which pilocarpine goes through with an electric current, stimulates the sweat glands to produce sweat. And if there is CFTR dysfunction, you don't have you lose the reabsorption of the sodium and chloride through the CFTR and end up with a very hypertonic sweat. So a sweat chloride test that will have a really high concentration of chloride, 60 and above. We also know that you don't need 100% functional CFTR to be healthy and asymptomatic. So carriers of the CFTR, those who have only a single mutation of CFTR, and so therefore 50% function of CFTR, are perfectly healthy and have no symptoms at all. To have cystic fibrosis, you need less than 15 to 10% CFTR function. But it had become evident through time that there is a spectrum to disease, and there is a subgroup of people who do not meet the criteria of cystic fibrosis who are symptomatic, and this is called CFTR related disorder. This is a subgroup of people who have some form of mono or oligosymptomatic clinical entity. So oftentimes acute pancreatitis, recurrent pancreatitis. In males in particular, they often have congenital bilateral absence of vas deferens or sinopulmonary disease, which is associated with evidence of CFTR dysfunction, but that does not meet criteria of cystic fibrosis. The clinical manifestations of CF are really, really wide, head to toe. I'm just going to give a brief overview so that you can appreciate how multisystemic this disease is in fact. So it starts really with lots of chronic sinusitis and chronic sinus symptoms, which is often quite symptomatic and requires recurrent surgeries. In terms of pancreatic disease, people who have milder mutations, so more functional CFTR, they'll tend to have acute recurrent pancreatitis attack due to ductal obstruction from those viscous secretions. And eventually that might lead to chronic pancreatitis, which is very debilitating, very painful. And unfortunately, there's no good therapeutic options. There are no good therapeutic options that are available for chronic pancreatitis. Versus 85% of the CF population is going to have exocrine pancreatic insufficiency from infancy, which is going to be related with a lot of fat malabsorption, a lot of malnutrition, and they need to be on lifelong pancreatic enzymes, several pills a day, and need to be on high fat and really high energy diet. And some of them even need to be fed with PEG to meet their calorie needs. And this shift of high fat, high energy diet happened in Canada earlier than the States. Actually, this was implemented across Canada in the 1970s. And this explained in large part the survival advantage we had in the 1970s as compared to certain other clinics like in Boston, who are really focusing on giving their children a low fat diet, thinking that that will be better for the pancreatic insufficiency. When you destroy enough of the pancreas, you also lose a significant amount of beta cells, and you affect alpha cells as well, which results in insulin insufficiency and insulin resistance, and that contributes to development of CF-related diabetes, which about 50% of adults end up developing. This is separate from type 1 diabetes and separate from type 2 diabetes, but has features of both. And unfortunately, oral hypoglycemics aren't really effective in CF-related diabetes, so they really need to be managed with insulin therapy. and require screening on a yearly basis with A1Cs and glucose tolerance testing. CF-related liver disease is also common. It generally develops in childhood, so around age 10 is the median age of diagnosis of CF liver disease. It's usually mild, but about 5% will be severe CF liver disease requiring, with severe portal hypertension and requiring liver transplant. And so again, it's characterized by that thick secretions with decreased bile flow and more toxic bile, more bile precipitation, which will cause focal biliary obstruction, and then eventually cause a focal periportal inflammation and biliary, patchy biliary cirrhosis. There's some modifier genes that play an effect in the development of CF liver disease as well. There's a whole slew of GI effects as well and clinical manifestation. The more common ones being the adult equivalent of meconium ileus, which is the obstruction of meconium in the ileum, is called DIOS, the distal intestinal obstructive syndrome, where you have a stool that are again very, very thickened and acidic and abnormal that ends up getting stuck either partially or completely, and causes pain attacks essentially as well, and constipation attacks. And this is often managed by osmotic therapies like laxatives and PEG therapies via NGs and enemas, and to the very, very rarely extreme cases might require surgery, but it's often it can be medically managed. We know that CFTR is also a tumor suppressant gene. This was discovered in mice models and then confirmed in humans as well, that there is a higher incidence of GI tract malignancies. So the standardized incidence ratio of colon cancer is about 6.7 versus small bowel cancer is about 11. It's about 11. So our consensus guidelines do recommend colorectal screening with colonoscopy starting at the age of 40. In all adults with CF, and to rescreen every 5 years, and if abnormal every 3 years, and earlier in those who are transplanted since the age of 30. There also is male infertility, which is in 99% of males with CF, biological males with CF will be infertile. And this is attributed to the absence of vas deferens. So they'll have obstructive azoospermia. There's sperm in the testicles, but there's no vas deferens. And so it does not come out. And they can have their biological children through sperm aspiration and then intracytoplasmic sperm injection and IVF. And oftentimes the development of vas deferens is actually very exquisitely sensitive to CFTR function in utero. So people who are who have CFTR related disorder, males with CFTR related disorders, often have congenital absence of vas deferens as well. Women are not infertile, but they are known to be subfertile. There is CFTR that is present in the cervix that contributes to that thick cervical plug. There's a CFTR present in the uterus as well, which affects the uterus fluid volume, which affects its acidity, and which affects also its microbiome. And all of this affects sperm capacitation, sperm migration, and implantation of the embryo as well. And then finally, CF lung disease, which is quite significant and the major cause of morbidity, as we talked about earlier, is characterized by thick secretions that really plug up the bronchi and cause a lot of obstruction, difficulty with the mucus clearance, more infection with bacterial growth, and eventually a lot of inflammation and further destruction. It is also characterized by repeated chest infections with further destruction and loss of lung function. Here is a picture of a CF patient with significant bronchiectasis, so these really dilated airways. It usually is predominantly in the upper lobes, but not limited to the upper lobes only. And so a lot of our therapies, and particularly our respiratory therapies, are really focused on the downstream effects of CFTR dysfunction and of CF. So really treating this cycle of mucus obstruction, inflammation, infection, but doesn't really act on upstream what's going on. And so we try to do therapies of, physiotherapy and mucolytics, so nebulizing liquids that will help thin the secretions, antibiotics to help decrease the burden of bacteria, and anti-inflammatory medications as well to really try to cut down the cycle. But again, it really acts on the downstream consequences. And we know that in the CF lung, when there is growth of certain bacteria, such as Pseudomonas, for example, there is decline in lung function. And every time patients with CF have exacerbation, that leads to further loss of lung function. And eventually, with significant recurrent exacerbation, that really precipitates the decline of lung function and leads to either death or transplant. So therapies that we try to use to alleviate all of these consequences are nebulized therapy. So they nebulize mucolytic to help thin the secretions, and using a compressor and a nebulizer. And this is often to be done at least twice a day, and it's 10 to 20 minutes of nebulization that's done. Then they need to do chest physiotherapy to really help bring out that mucus. So they use either these devices and then do breathing exercises with these devices, or when they're young or they're in hospital sick with an exacerbation, they get chest physiotherapy from someone else. So clapping and percussion to help dislodge that mucus and help them expectorate it out. And once they've done that, then they need to go back to the nebulized therapy and nebulize some inhaled antibiotics, which is another 10 to 20 minutes of nebulization, and they need to do that 2 to 3 times a day. So the burden of therapy in CF is quite extraordinary. Respiratory therapies alone are 2 to 3 hours of therapies, and since childhood, we're talking about childhoods and young adults needing to spend 2 to 3 hours of their day just on the respiratory therapy. Then you add everything else, daily sinus regimen twice a day. They need to focus on taking a high-fat, high-energy diet, so really eating a lot. And if they can't meet their calorie needs, they often can need a PEG tube and need feeding overnight to meet their calorie needs. They need to take sufficient enzymes with every fat-containing meal. So we're talking about 5 to 8 pills with every meal. They need to take insulin with all of their meals, really high doses of vitamins on a daily basis. They need to do regular bowel regimen. And if they have chest infections or exacerbations, then they need to be on oral antibiotics or come in for IV antibiotics and recurrent repeated admissions as well. And then on top of all of that, of course, like with all our patients, we tell them to exercise, which they need to fit in at some point during their day as well. And all of these aggressive therapy management has made a difference in the median age of survival. So, we were talking about disease recognition, which had disease recognition less than 3 years, and then eventually that had gradually improved. And in the 1990s, we were talking about a median age of survival of around age 30, and progressively with each incremental therapy innovation that has increased. And with this aggressive approach, in 2019, we were in Canada at the median age of survival of about 54 years, which is quite remarkable. And Canada, compared to the United States, in this paper that garnered a lot of media attention, showed that there was actually a survival advantage to CF patients in Canada, a difference of 10 years compared to the United States. And part of this differential advantage and survival benefit is attributed to probably better access to healthcare here and less healthcare disparity in Canada for our CF patients. Okay, so we do all of this therapy and it really focuses downstream, but what about taking care of upstream? So addressing the CFTR gene defects or the ion transport, defective ion transport, what about focusing there? So it took a really long time to develop therapy, and part of the reason why was that really pharma was not quite interested in developing therapies for CF. It wasn't believed to be very cost effective or very interesting in terms of a monetary return for a genetic disease that is a common genetic disease, but other therapeutic options were tried and they weren't quite successful. It's in 1999 that the CF Foundation then developed this model that they called venture philanthropy that really changed everything. So they came up with this model where they decided that they would give their funds and their donations to a for-profit organization, to a pharmaceutical company, and to help which will they'll invest it in them and de-risk their investment essentially and help fund CF research. And in 2000, they made their first big donation of about $40 million to a pharmaceutical company. There was only 2 pharmaceutical companies that were interested in this, and eventually ended up choosing one. And it is the pharmaceutical company that ultimately developed all of the CFTR modulators that I'm going to talk about now. So the CFTR modulators, it's not gene therapy. They're basically drugs that act on the CFTR protein and helps improve its structure. It corrects the defect, it enhances processing, and it also potentiates function. It doesn't modify the gene, it does not affect the CFTR gene itself. They classify them in two big categories. So we have the correctors that will function to restore the normal processing of the CFTR and normal trafficking of the CFTR protein, and the potentiator that's going to help open the channel. In 2011, the first big drug came out, which was a big game changer, which is called Kalydeco or ivacaftor. It showed that it was studied in patients with CF who had a mutation of G551D, which is a gating mutation where the channel doesn't open. Their FEV1 was between 40 to 90%, and it showed a remarkable improvement, an improvement of 10.5 absolute percentage points at the end of 48 weeks, but starting as early as 15 days. There's also a significant reduction in their pulmonary exacerbations, a significant improvement in their quality of life score, a significant improvement in their weight gain as well. And we could see that their CFTR function had improved as well from a mean of about 100 down to 47.8, demonstrating that the function itself was working quite well. And then subsequent studies also showed real-world benefits as well. So less patients on ivacaftor that needed transplant, there were patients coming off the transplant list, and even a survival benefit that was noted of patients on ivacaftor. And then subsequently, ivacaftor was approved for patients with other gating mutations as well, which encompasses about 5% of the CF population. So, okay, we've taken care of 5% of the CF population, but what about the rest of the 90% of the population? So what about patients who have delta F508? Delta F508 is a complex mutation. So yes, it is a class 2 mutation, it's most folded, but there are other features that makes it complicated as well. So when the mutant CFTR protein makes it on the cell surface, it actually doesn't really open. This open probability is quite low, so it has features of class 3 dysfunction as well. And its metabolic disposal is 4 to 6 times higher than wild type CFTR. So it has features of class 6 mutation as well. And so the Vertex tried to develop a CFTR modulator that would combine a corrector, so that would help its processing and trafficking and the folding of the CFTR with a potentiator, ivacaftor. So the first generation of that was Orkambi, which was lumacaftor and ivacaftor, and really the benefits of that were quite modest. The absolute change in FEV1 were not that impressive, 2.64%. It did help stabilize a little bit in terms of the reduction in pulmonary exacerbation, about 30%, but it had a lot of drug-to-drug interaction and also a lot of respiratory symptoms, particularly people who had lower lung function ended up oftentimes with exacerbations with drug initiation. Next, they tried another corrector called tizacaftor combined with the potentiator ivacaftor, and this is Symdeko. And again, the results were modest. There was an improvement in FEV1, so a 4% absolute change in FEV1. It did reduce pulmonary exacerbation, and it was much better tolerated. You didn't have the acute respiratory symptoms. You had less drug-to-drug interaction, but overall, real-world data was still modest at best. It wasn't groundbreaking like the way ivacaftor was for gating mutations. And so then the next hypothesis was, how about if we combined 2 different correctors to a potentiator? Would that make a difference? And so they used a newer generation of a corrector called elexacaftor with tizacaftor, and combined with ivacaftor. And that first landmark study that came out was in 2019 with using this triple therapy now known as Trikafta, and they compared it in patients who were homozygous for delta F508. It was a double-blind active control trial, so patients were a 4-week run-in period where they were both groups were on Symdeko, so tezacaftor, ivacaftor, and then 1-to-1 on either Trikafta, so triple therapy, or continued with Symdeko. Their FEV1 was 40 to 90% predicted, and it was in 12s and older. And the results were astounding, similar to ivacaftor, which showed an incredible improvement in absolute percent predicted FEV1 by 10 percentage points at 4-week point, but even by day 15, a big jump was noticed in the lung function. Their sweat chloride went down significantly, so improved by 45 millimoles below the threshold of the diagnosis of CF, so proof that there is restored improvement of function of CFTR. There was significant improvement in quality of life and significant weight gain at week 4 as well. And so that was done in people who had 2 copies of delta F508, so homozygous for delta F508. What about people who had a single copy of delta F508? Would triple therapy, so Trikafta, still work in those people? So the subsequent study that came out a few months later, the New England in 2019, looked at just that. People who had 1 copy of delta F508 and another severe mutation, so another minimal mutation that would not result in functional protein. Again, it was 12 years and older with FEV1 of 40 to 90% predicted. And again, a big improvement was noticed. So this time there was a 14 percentage point difference in absolute FEV1. And remember that the other group were already on, it was an active control, it wasn't placebo control. So they were already on Symdeko that conferred that 4% improvement. And then you had the 10% added on top of that. And so this compared to placebo, we would have a 14% improvement in lung function, but more than just the numbers being better, there was a significant reduction in pulmonary exacerbation by 63%, a significant improvement in quality of life. So we're talking about patients who stopped coughing, who stopped having sputum, who started being much less dyspneic, and BMI improved as well. They examined, there was another study that came out just a few months ago that also compared Trikafta to people who had delta F508 and a gating mutation that were already eligible for that first drug, ivacaftor, Kalydeco, and showed that there was still an added improvement on being on Trikafta versus just ivacaftor alone. The FEV1 improvement by week 8 was about 6% when compared to triple therapy to ivacaftor alone. So clearly, there in all populations who had at least 1 copy of delta F508, there was an improvement in their lung function, in their symptoms, in their pulmonary exacerbation. So study findings were quite remarkable, but we also in real world found that there has been fascinating changes that were observed as well. So this is a prospective observational study that came out in the Blue Journal in 2021 that looked at Trikafta in patients who had advanced lung disease. So advanced lung disease as defined as percent predicted FEV1 less than 40%. And in this cohort, the median percent predicted FEV1 was 29%. And they found that in their group at initiation, when there was 43% that were on long-term oxygen therapy, by month 3 on Trikafta, this went down by half to just 23% needing still oxygen. At initiation, 28% were on non-invasive ventilation. By month 3, only 20% needed non-invasive ventilation, so a significant difference. And in terms of enteral feeding through PEG tubes or G-tube, 18% needed that at initiation, down to 10% by month 3. Also found a big difference in terms of transplant. So by study initiation, there was about 53 patients that were on the lung transplant path. So they were either referred to transplant or they were on the waiting list or they were on the transplant waiting list. And at the end of the follow-up period, those 53 patients went down to only 5. So 2 patients ended up being transplanted, but the rest of the 5 were 4 were on the transplant list and 1 was referred for lung transplant. So a big improvement. and improvement that us as CF physicians have also seen in our real life practice as well. So this is an anecdote of a patient that I had followed during my fellowship, just because of how remarkable the difference is. So this is a patient, a young patient, a gentleman who was admitted in December with a drop in lung function. So he had a baseline of about 1.4 liters, 40% predicted FEV1, and this had dropped down to about 1.1 liters. He had a really resistant bacteria and was very, very difficult to treat. So he was admitted for about 2 months, trying various different regimens of antibiotics, special access antibiotics, trying courses of steroids, various combinations of different therapies, and we made no improvement in his lung function, no improvement in his symptoms. He was stuck at 1.1 liter and would not budge. He was down to 26% predicted, and we were really starting to think that we've reached a new baseline, and this we'll need to list him for transplant. At the time, we were able to access Trikafta through compassionate use only, and so you needed to have significant low lung function for about 2 months, and so we were able to apply him for compassionate access of Trikafta. The day before Trikafta was initiated, we had repeated his lung function, and again, no improvement. He's still at 1.1 liter. We started Trikafta the next day, and within 4 hours, he comes out of his room running to the nursing station, telling us that he's a new man, he feels fantastic, and he's noticed a difference already. He wanted his lung function done immediately, and so we decided to humor him and did his lung function. And for the first time out of those 2 months, we've actually saw a movement in his lung function. It went up to 1.25 liters. More than that, he was feeling well for the first time in 2 months. He's coughed up all of his mucus. He felt much less congested in his chest, and he felt good. A week later, 7 days later, his lung function went up to 2 liters. And then at follow-up at 6 weeks, his lung function was up to 2.96 liters, or 73% predicted, which is incredible and way more than trial findings of 14%. And so if, as a trainee, if you showed this lung function change and would ask what happened for someone who went from 1 liter to almost 3 liters, the answer to that would be lung transplant, not taking a new medication. And similarly, we can see radiographically that there's a big difference as well, and an improvement in all of the mucus plugging. And while we don't see a reversal of the bronchiectasis, we just see that there's much less inflammation and infection and mucus impaction in the lungs. Trikafta is pills, basically. So it's 2 pills to take in the morning and 1 pill to take in the evening. And the sticker price of this drug is $300,000 USD a year per patient for medication that they need to take for the rest of their life. It took quite some time for Trikafta to come to Canada. So the initial studies that I had showed you came out in 2019, and shortly thereafter, it was approved in the States. And in 2020, it was approved in 20 other countries across the world, but not approved in Canada. And the big reason why was that Vertex, the drug company, had not submitted for review for Health Canada due to recent changes that were made a few years ago to the Patented Medicine Pricing Review Board, in which certain policies made it not interesting for drug companies to submit their drug for approval. And one of the policies was that they wanted transparency of the negotiated drug price, which is not something that is in Big Pharma's interest at all, for there to be transparent drug negotiation. And so with a lot of work from patients, from families, from all these different CF advocacy groups, from physicians who published data, who compiled data, who advocated on their behalf, there was a reversal made from the PMPRB, and then finally Trikafta ended up submitting for Health Canada review in 2021, which was approved then in June 2021, and then all of the provinces went through their review, and CADD and INES as well, and Trikafta is now available for prescription as of October 2021. It was approved by RAM2 coverage at end of September 2021. We're only now starting to be able to prescribe this for our patients. overall a really well-tolerated medication. So common side effects include rash, which was present in about 10% of the study participants. It's often self-resolving with drug continuation, but very rarely do we need to stop the drug and then reinitiate it at lower doses and incrementally increase. There were CK elevations and none of those led to drug discontinuation. And the hypothesis is that it's probably related to patients just being a lot more physically active, doing more exercise. And so we're seeing a bump in the CK without, any evidence of myositis. Elevated liver enzyme is the main thing that we do look out for. It's present to 5 to 10% in the study population. And it's not entirely predictable who we will see these elevated liver enzymes. It's not entirely clear who we will see these elevated liver enzymes in. It's contraindicated in patients who have, or at least not recommended in patients who have cirrhosis child PUC. There's a dose reduction recommended for patients who have child PUB, and no change in recommendations for people who have child PUA cirrhosis. There has been some reports, very few and very rare, but there has been some reports of a liver failure leading to liver transplantation after an initiation of Trikafta. So this is the one thing that we do monitor for quite regularly. Abdominal pain is common with initiation, and part of the hypothesis is that it might be related to the viscous biliary sludge starting to become a little bit more mobile and might cause a little bit of intermittent impaction and obstruction and some pain related to that. Rarely, but it is described, it can precipitate acute cholecystitis, and it has been also described to precipitate attacks of DIOS, so that obstructive constipation essentially. It is common for it to cause headache with initiation. That usually gets better with time. There's some reports of testicular pain. There's reports of elevated blood pressure. There's a trend of weight gain. And then in a subset of patients, there's a trend of significant weight gain as well, to the point of some certain patients becoming overweight or even obese, which has led to our CF clinics to start thinking about modifying our recommendations that we make to our patients, particularly dietary recommendations we're making to our patients. And in a small subset of patients, there's also neuropsychiatric changes that has been observed and reported. It's not clear how much of that is drug effect, and part of that is also probably explained by the part that, we have these young patients who always thought that there was a time limit to their life, who were very acutely aware of their mortality and envisioned themselves as dying. I mean, a subset of our adult patients, as they go through pediatric clinics, are told by various people that they're, they have a limited life expectancy. And that practice is not common now at all, but there are adults that in the past had been told that. So they have this acute awareness of their mortality. And so now that you've started a drug, they have that completely changes all of that. They have to now start thinking about a job and an occupation and retirement and living for decades, which can be, while that is good news, that's actually quite destabilizing to patients as well. There are a couple of drug interactions that prescribers need to be aware about, particularly when we're talking about CYP3A inducers and inhibitors. There are drug modifications that need to be made. It's not clear how much Trikafta is going to improve survival, and it's clearly going to improve the median survival. We don't know yet by how much. This is a modeling study that was done using registry data out of Toronto. That was part of the advocacy work, actually, to convince the PMPRB board to reverse their decision. And this was a modeling study that showed that if Trikafta was available in 2021 versus delay in 2025, that there would be a significant change in their estimated survival. And as per their modeling, if it was initiated in 2021, there would be an estimate increase in median survival by 9 years in 2030. There's still so much more to do while all of this is incredibly exciting. So in particular, what to do about all those who don't have a copy of Delta F508. They are working to see if modulators work in other mutations as well. But what about those who produce no protein at all? We know that there's significant variability as well within groups of patients who have the same mutation and the same mutation class. So what exactly explain that is the role of modifier genes. How do we make in vitro and in vivo correlations? What are the long-term impacts of CFTR modulator? Is it an impact that's going to last lifelong, or is it going to lose its efficacy? What about the long-term effects on pancreas and diabetes and liver disease? And what about cancer risk and cardiovascular risk? All of these questions are still yet unknown. We lost some of the big therapy burden that we talked about. Can we stop doing so much of their inhaled therapies, for example? And if so, which ones? We don't know that yet. There are trials right now in RCTs, like the Simplify RCT, going on in the States right now to help answer some of that question. And then finally, can we individualize therapy to the point where we can take cells from patients, and that's being done in research right now, but not yet on a clinical basis. But can we take cells from patients and test different modulators on those cells and figure out which modulator is going to work best for them? So, we've come a long way, but there's still a long way to go. We haven't found a cure for CF yet, but in the near, not so distant future, we might be able to come to a point where, we're already at a point where we have newborn screening and we have identification of CFTR mutations. And then can we progress to a point where we'll find several modulators and individualize to the best modulator therapy for each patient, initiated at an early enough age to completely prevent the development of symptomatic disease and prevent the development of bronchiectasis, and then just apply all those downstream therapies on an as needed basis, and then eventually can CF no longer be a life-threatening disease.
Thank you so much. Really terrific lecture, Dr. Swaleh. Thank you. Very, very exciting to see the progress in this field, because certainly when I was a medical student, it was a death sentence, I think, when many of us were in medical school. So as you pointed out, thank you. Really terrific. We have a few questions. Bettina Lini wants to know, in that young patient that you presented, why was it so difficult to get the modulators, given the dramatic results that can occur, in these kind of patients? Why was he only able to get it on compassionate care?
Right. So that was in 2021. So that was February 2021. So Trikafta was not approved in Health Canada yet, and in fact, it was only approved in Health Canada in June 2021 because of what I had described, the PMPRB board decisions that were made at that time, which made Vertex, the company, not submit. They did not submit Trikafta to for Health Canada approval because it was just not in their interest from a monetary standpoint, from a financial standpoint, to do that. And so Trikafta was not even submitted to Health Canada, and it was not an option. Trikafta was, however, allowing on a very compassionate and strict basis to approve certain patients to get it. And so one of their strict criteria was that you needed, if you were homozygous for Delta F508, which this patient was, you needed lung function of 30% and less for at least 2 months to be approved. And so as soon as he met that 2-month mark, we applied him for compassionate use.
Terrific. Tell us about, David Rosenblatt wants to know something about, can it be given pre-symptomatically? Or does it have to be given once there are symptoms?
So that's a great question. So right now it's approved it's going to be now approved from 6 years and older, and it's being studied in younger patients as well. We think that probably when it's approved for a younger patient population, we might probably not get symptomatic disease development at all. The frustrating part right now is that because all of these studies were done in patients who had FEV1 of 90% and lower, and because of the extraordinary drug ticket price, although the price has been renegotiated and we don't know what that renegotiated price is, and there's still a limit that you need an FEV1 of 90% and less to apply for this medication, which does not make sense. And there's a lot of advocacy work being done right now to try to reverse that decision. And there are some exceptions that can be made on a case-by-case basis. But RAMQ, for example, can refuse me if I apply for a patient who has less than 90%. They'll ask for additional justification, and ultimately they can refuse the decision. So the goal is to try to get it to people who are started as early as possible, and people who are minimally symptomatic as well. But right now, as it is, it's approved for patients who are FEV1 of 90% and less.
Okay, so Marcel, you have some questions. There's a couple of minutes left, so if you want to unmute yourself, Marcel, you can. You have 2 minutes.
Okay, thanks, Sana. Great talk. I have a fundamental question. You had that slide of the bronchial cell, the cartoon that leads all the understanding of the biology. But is the acquisition of Staph aureus, Pseudomonas, mycobacterial infection, is that actually happening in the bronchi, or are the same defects happening in the upper airways?
So we know that those defects are happening in the upper airways as well, and we know that patients who have Staph aureus in the lungs also have Staph aureus in the sinuses and in the upper airways. Patients who have Pseudomonas in the lungs will have concordant Pseudomonas in the sinuses and in the upper airways as well.
Thank you. And then I have a clinical trials question, not so much for you, but it was raised here, and
okay.
Maybe the clinical trialists can answer to me. The Lancet article, you showed that there was a run-in period before the randomization. And my understanding from Peter Gotch's book that I read 5 or 10 years ago was having run-in periods before randomization can overestimate the benefit-harm ratio because you only bring people forward who tolerated the drugs during the benefit period. Is that the norm in these studies? And does it lead to some overestimation of effects?
So is that question for me, or was that for the person who?
It's a rhetorical question, but I guess is it the norm in the studies that you're seeing as well, that there's a run-in period before the randomization?
So for patients who are eligible based on their mutations for other modulator therapy, so for example, the ones that I showed were homozygous for Delta F508, so they should be on Symdeko, which is an earlier generation of modulator therapy. Then yes, it is common to compare, to have a run-in period where they're on modulator therapy to see if this modulator therapy is better, because these patients would be on modulator therapy anyways.
Okay, thank you.
I have
thank
one
you,
comment,
Jeff, go ahead.
I have one comment, Dr. Matouk here.
Yes, go ahead, Dr. Matouk.
Excellent, Sana, excellent presentation. I just have one comment here, is that the eligibility criteria in the US are different from Canada. And in Canada, they have added several mutations where they tested them in the lab. And by serotyping, if there is an increase of greater than 10%, if the chloride conductance, as measured by short circuit current greater than 10%, they are eligible for the medication. By doing that, they have added 177 additional mutations. This eligibility criteria is not available in Canada. We have been serotyping all our patients by human nasal cell harvesting and conditional reprogramming. And we've been very successful in doing that, in identifying those patients that will be eligible, at least in the US, but not in Canada. And we are trying very much to put their eligibility as part of the Canadian eligibility. And the other point is that those patients that have a greater than 90% FEV1, whereby the major brunt in the pediatric population, where they will benefit the most by early starting of the Trikafta, we are still fighting for that. So we have two things that we're going to fight for. These are the major two, that we have the serotyping in this patient and those that have greater than 90%. And then we have those 10% where there is no drug availability with them. And we are trying very hard, and I'm sure in the lab, to find modulators for them. There is one modulator that is coming, corrector, called X121, plus a deuterate ivacaftor, which is a long-acting ivacaftor, which the study now is being in the stage of recruitment. And unfortunately, we didn't see much patient that will be eligible from our clinic to enter into the study yet. So as you said in your last slide, there is a lot of work to do. And I just take the opportunity to congratulate you on this excellent conference and excellent talk. Thanks, Sarah.
Thank you
Thanks
so much
for your points, Dr. Matouk.
Thank you so much, Dr. Matouk. Jeff, you have 1 minute left.
Okay, so there are so many heterozygotes in the populations. What are the recommendation of testing for heterozygotes. I presume you do the testing in families of identified homozygotes, but is there any general recommendation for populations?
So for the general population in of itself, if they're completely asymptomatic, then we would not test. If they have, we would test patients who have partners, who are known CF or known carriers of at least one mutation, then we would test their partner to see if they're a carrier as well. Have a 5% risk of having, with each pregnancy, of having a child with CF. So we test symptomatic people, and then there's newborn screening that's done at birth, essentially, which would test, as I said, 90% of the patients with
and it does
CF will
test
be
for
captured.
all mutations, all classes of mutations are tested by newborn screening.
No, so there's an algorithm to
Can
the
I
newborn
ask you,
screening.
Asana? I'm going to interrupt you because it's 1 o'clock. I'll let the two of you continue, but I just want to thank you on behalf of the department. Thank you so much for really this wonderful talk. Very, very informative. And there's great comments in the chat. I invite you to look at those comments, a lot of great comments, and I'll let the two of you finish your conversation. Thank you, everyone, for joining us today. Bye-bye.
Thank you. Thank you.
Thanks, Dr. Jainati. So yeah, no, there.